Thank you very much, David. It's a pleasure to be here. Thank you to the organisers for asking me to come and speak. I love coming to this conference. I'd like to add my welcome to you, and actually I'd like to congratulate all of you for making it here, especially those of you who have very young children. I noticed in the delegate list that there's a child of just 2 weeks of age. I don't know if they've actually managed to come, but I mean, one of the thoughts I have is what a shock it is to have a baby with a condition like this where major surgery is required within such a very short time after birth. And I was musing about a possible funding project for the TOFS committee, actually, which might be to investigate the management and investigation of post-traumatic stress disorder in parents of TOF children, because it must be such a difficult thing. But I do want to offer a message of hope. With TOF and VACTERL, for the most part, the majority of the time, the worst of it is right at the very beginning. And things gradually improve. And there is a realistic expectation that you out there who are the parents of babies with a TOF will one day see a picture of your grown-up child graduating from university or flying an aeroplane, as has happened and been reported. I don't diminish the problems. They're all there actually for you to see that can occur as your child grows up. But that's not something I can say by any stretch for all of the patients who come through my genetics clinic, where that is not a realistic expectation at all. So do have hope. Yes, why? Well, it's not the main issue. I know the main issue is to make sure that your child is medically and surgically cared for. But at some point, many of you will ask this question and want to know what underlies it. Why has it happened? And in some cases, we have some ideas. In other cases, I regret probably the majority, we still don't understand. But I'll take you through what we know, and we can have a little discussion about it at the end, and I'm always happy to hear questions from the audience, and I'll try and leave a decent amount of time for questions. I'm a clinical geneticist, and so we don't offer any treatments in terms of operations or tablets or anything like that. And we talk about the fact that our treatment is knowledge and information, which sometimes is very important to families. They do want to have that. And there are, in a very small subset of cases, there can be heritable causes of TOF, which I'll cover. And so clearly, if that were the case for a family, then it would be something that I'm sure you'd want to know about, because it's difficult enough having one child with a TOF, but to have more than one is... Although actually I was just talking to Darryl, who's doing brilliantly looking after 2 children with a TOF, so well done. Here are a few facts and figures. About 1 in 3,500 births. About half of them, depending on the way you look at the data, I won't go into that, but about half of them, there are additional problems, and the VACTERL comes into that, but it's not just that. There are other types as well, and we use the terms syndromic and isolated, which are quite helpful to geneticists. So half occur on their own. It seems to be just a TOF and nothing else. And the other half, there are other things which might be additional malformations, or there might be developmental issues, and so on. There doesn't seem to be any association with maternal age when you rule out the fairly small subset with a chromosome problem, nor does there seem to be any geographical trend. And I regret the majority of the isolated TOFs. It is somewhat mysterious why it has happened. There are different subtypes of esophageal atresia, Tracheo-Oesophageal Fistula. In fact, from the geneticist point of view, and from the point of view of trying to work out what causes it, it doesn't seem to there aren't really any patterns to the subtype. So I just generally talk about TOF and OA as a generic thing without going into the specific subtype, although of course from the surgical point of view, that's very important. It feels as though I'm really loud, but am I? Oh, I'm not too loud. It's fine. Okay, good. So some of the things that I'll cover then. there aren't really any well-documented instances of some kind of exposure during pregnancy leading to TOF. I'll cover those a bit. Being a twin is possibly a factor. Well, I think it is a factor, and I'll say a little bit about that. The chromosomal conditions, yes, and then there are some single gene conditions, which I'll talk about also. I do want to make one point, though, because although we often don't know the cause, I know from being a geneticist that where there is no explanation, parents invariably will come up with one which may or may not be correct. I'm sorry, it's probably always not correct, actually. And it could be that they fell down the stairs when they were 14 weeks, or they're in a car accident, or they went past a field being crop sprayed with the window open in summer, or they painted, or they did some gardening, something. That was the cause. But I do want you to be aware that the development of the esophagus and the trachea happens at an amazingly early point in the pregnancy. It's pretty much happened by the time you realize that you're pregnant. So between 4 and 8 weeks, these things are happening. The rest of the pregnancy is just growth. So the sort of intricate plumbing of it is already complete by about 8 weeks. So anything that happened after 8 weeks is completely irrelevant in terms of the possibility of developing a TOF, because the development sort of can't go back and then forward again. So if you have got any of these ideas and they're after 8 weeks, they're almost certainly not the cause. There's a bit of suggestion that if the mother has diabetes, certainly there are some congenital malformations that are more common in infants of diabetic mothers, but there's not very good data that TOF is one of them, actually. There's not very good data about alcohol either, but it's best to avoid drinking alcohol in pregnancy, we all know that. Some drugs to do with the thyroid, there's a few case reports in the literature which seem to amount to a pattern that they can be associated with TOF. That's been reported, but that is known now, and they are avoided and not prescribed during pregnancy. And I'm afraid that's just about all we know about fetal exposures. And there's not really very much from animal models either, so not terribly helpful. Being a twin, there's a bit more information about that, and I must admit, I personally everyone finds twins interesting. They just are fascinating. And there's some stuff about twins that you wouldn't necessarily expect that I'll take you through. So first of all, if you are a twin, then that in itself is a risk factor for quite a wide range of congenital malformations, say heart problems, kidney problems, and also esophageal atresia, Tracheo-Oesophageal Fistula. So if you take the population as a whole, about 2% of people are twins, either identical or non-identical. But if you look at the population of children with a TOF, about maybe 4 to 7% of them are twins. So there's something about being a twin that seems to be a risk factor for it. So what is going on there? The first thing I think it's important to say is that the twin concordance rate is very low. So what do I mean by that? It means that usually if one member of the twin has a TOF, the other one doesn't. Okay, and in fact, if we're thinking about genetic factors, you normally see quite a high concordance rate. In other words, both twins have got it, and that's usually taken as a piece of evidence that something could be genetic. So one study looked at 80 twin pairs, and in fact, only 2 of them were concordant. So of those 80 twins, in only 2 of the twin pairs did both members of the twin have a TOF. And in the other 78 pairs, just one of the twin pair had it. Any twins in the audience, by the way? I also quite like to. Yeah, so there's always twins here. Now, the other point about it is, although there isn't direct evidence for this, if you're thinking about identical versus non-identical twins, there's some indirect evidence that monozygotic twins, the incidence, if you look at the population of children with a TOF, is higher than expected. And this has been worked out indirectly by looking at the gender, the sex of twins where one of them has a TOF. So around 70 to 80% of twin pairs of which at least one has a TOF, are like-sexed, so they're male-male or female-female. And the female-male ones are underrepresented, so only 20 to 30% of those. Now, that's not what you'd expect, because non-identical twins are much, much commoner than identical twins. So what this is saying to us is there's something about being an identical twin that seems to be a risk factor for TOF. And this is not just true of TOF, it's true for quite a wide variety of malformations. And in fact, when identical twins happen in a very different way from non-identical twins. So non-identical twins, you have a separate egg and a separate sperm that come together. With identical twins, you have one egg and one sperm, and then you have some embryonic development, and then they split. And in fact, the Siamese twins are like an extreme version of that, where the splitting didn't quite happen, and they stayed as one conjoined embryo. But there's a suggestion that there's something about that splitting of the embryo process that might make one of the twins prone to having a congenital malformation. And although there isn't a lot more information about that at the moment, it seems like a sort of theory that makes sense. And there's another aspect to this as well, which is that you can have a singleton pregnancy resulting in a singleton live-born, but there's a little bit of evidence done by a guy called Paul Farrow that there may be a twin that was lost in early pregnancy, and that can present as an early bleed in pregnancy. So I always ask TOF couples, parents of TOF children, if there was any significant bleeding early in pregnancy. And sometimes if you do a scan at that point, you can see evidence that there was a twin, that there's a sac that no longer has a viable pregnancy in it. And it's possible that that represents, again, identical twins where one of the twin pair had significant congenital malformations that were not compatible with life. So maybe a major heart problem, something like that. So that's what I want to say about twins. Chromosomal conditions, completely different, of course. Best known as Down syndrome. And about 5 to 10% of TOF, they happen in children with one of these chromosome differences. So Down syndrome, or one of the other ones, Edwards or Patau. These are very rare, very small print, although most of us have come across a child with Down syndrome. But there are actually lots and lots and lots of much rarer chromosome conditions, and some of them are really quite well characterized and quite well known to clinical geneticists. For example, this condition called DeGeorge syndrome, or 22q microdeletion. So there's a tiny loss of chromosomal material that takes out a gene, a critical developmental gene that results in malformations. And there are many of these, and in a few of them, like this one, DeGeorge, there's a link with TOF, but they're very small print. And there's a danger of coming and talking about really rare stuff at conferences like this that most in the audience will not come across. But as a general take-home point, I suppose, all of these things don't apply to children where the TOF is isolated. These things apply where the child has multiple physical and mental problems, as with Down syndrome, for example. So in Downs, that's a set of human chromosomes, and there's an extra copy of chromosome 21 there, which you can detect on one of these specialist chromosome tests. And in fact, children with isolated TOF don't really need any of these investigations. It's only where there are additional problems, such as maybe malformations in the VACTERL category, or where there is clear delay in development or some other developmental issue, then the possibility of an underlying genetic cause should be sought, and referral to a genetic specialist should be considered. But for isolated TOF, not necessary. So this is the bit that I'm, professionally I'm interested in, and again I stress it doesn't apply to the majority of people here. But the thing about the genetic versions of TOF is that they're kind of tractable, by which I mean that there are a few clues scattered around that mean that we can actually home in on the why, what is causing it, and you know, that's what we're about. So we love investigating these because there's a chance we can actually get an answer. No one likes investigating a problem where there's no chance of getting the answer. And it's important to know about these for two reasons, I suppose. They can run in families, it's heritable, and there can be associated other clinical problems, as you'll see as I go through this. So if we were to say, well, which children with a TOF should see a clinical geneticist, then clearly where there's a family history of TOF, or where there are additional malformations or developmental problems that might mean that there's an underlying genetic cause. Okay? So there's a condition called Feingold Syndrome. Again, most of you will not have come across it. It won't be relevant to most of you. It kind of can masquerade a bit as VACTERL, and so it's important to distinguish the two, because Feingold Syndrome runs in families, so there's a recurrence risk, whereas VACTERL seems to be a completely sporadic event, which only happens in one child and doesn't have any other implications. With Feingold, clearly there can be esophageal atresia. You can also get duodenal and anal atresia, and there can be a heart problem. So it does look a bit like VACTERL. But they also can have mild learning difficulties and a slightly small head size. And the fingers and toes can have, and I guess they sort of bring out the detective in you, these things, because you're looking for quite subtle features that can provide a clue to what the underlying cause is. There can be heart or kidney malformations, and the gene has been identified, so we can do genetic testing for this. And this, you can see slightly unusual patterns in the toes, where they're a bit joined together, and in the fingers, and I'll get you all to look at your hands now. That's always quite an amusing part of the conference. You can get this slight incurving of the fingers here, and this middle section of the finger can be a bit shorter than it is otherwise. There's something called charge syndrome that, again, you might have come across. It can be associated with, my pointer's gone, not to worry, an unusual configuration of the eye, which is the thing that Madeleine McCann had, actually. That's called a coloboma. It can be heart or kidney malformations. Choanal atresia is blockage of the nostrils. The ears can be characteristic, and there may be esophageal atresia. And you would clearly, these children, they're not just TOF, they have a multiplicity of problems, and it's very obvious that there's something really quite individual going on. And they can look a bit unusual, and the ears can be quite characteristic. And again, that is diagnosable by means of genetic testing. And you know, it is useful to do that and to see a geneticist and to receive advice. And there's some other really small print conditions. I have to mention this one, even though it's incredibly rare, because it was a gene that I established a link between TOF and this gene, FOXF1. And that's when I did my fellowship and had some help from Vicky Martin. That was the main finding to come out of that, which was really interesting. I know there's people this is quite a recently diagnosed condition, and again, it's a bit like charge. You wouldn't miss it. There's clearly something more than just TOF going on. Again, diagnosable by genetic testing. Likewise, these, I won't go into more details about these, but again, there are multiple things going on, of which TOF is a component. Some of you might have come across this thing called the 100,000 Genomes Project. I mean, as a geneticist, it's very exciting at the moment because the government has put a lot of funding into making genetic testing more available in the UK. And children with rare genetic conditions were recruited to this, and there was actually a VACTERL category for it, so children with VACTERL were recruited. And that's coming to a close now, but the legacy of that project is that there's been a pretty much total revamp of the way genetic testing is organised and delivered in the UK, and that's happening at the moment. And one of the goals of that project was to make genetic testing not just the province of clinical geneticists, and we're quite a rare breed, there are not very many of us. They want people like paediatricians and other hospital specialists to get involved in genetic testing because it's so powerful. Obviously, this is not just to do with TOF, this is the whole range of rare genetic conditions, of which there are thousands and thousands. How am I doing for time? Am I fine? Does the yellow and red, does that mean you've got to the end of the total time, or?
Yellow is if you could wind it up and take questions.
Yeah, right, good. I'm nearly finished. Red means, yeah, we all know what red means. I suppose this is quite an interesting study because this chap, Cyril Carter, he was one of the first geneticists in the UK. He worked at Great Ormond Street Hospital, and he's like the father of our specialty in the UK. And for some reason, he was quite interested in esophageal atresia, TOF. And he did really quite a clever thing, which was before 1947, there was no TOF surgery, so I think it's fair to say that all TOF children died. They didn't make it. So nobody knew if it was something that could be passed on to the next generation or not. And so, you know, that was a completely unknown question, and he wanted to try and get the answer. So he traced adults, the first adults who'd had the TOF surgery and who'd survived to adulthood and who'd actually had children, to see if it was something that was an inherited thing or whether in fact it wasn't. And that study was published in 1979 and still gets cited. In fact, his conclusion was that the chances of a grown-up child with a TOF having a child with a TOF is very small. Mostly their children are fine, which is useful to know, actually. And in fact, when you look at the paper and you look at the instance where there was a child with a TOF born to a TOF adult, there were some features about that made it pretty obvious to me, although the syndrome wasn't actually described at the time, that this is Feingold Syndrome. So essentially, if you take all the Feingold Syndrome children out of this, who are a very special case of TOF, then what we're saying is that pretty much no chance of it being passed on. It's something that happened in that child as that child was developing without any implications for future children. And this is also true of VACTERL, which is, I regret, again, still quite poorly understood. And one of the issues with it, it's quite hard to define exactly what it is. And Vicky and I spent time trying to do this a little bit. Because there's no sort of gold standard test to say this child is VACTERL, it's a descriptive diagnosis. You're saying if a child's got 3 or more of these things, then we're going to call that VACTERL. But because we don't know what causes it, then it gets quite messy at the boundaries about saying exactly who does and who does not have it. But there are a couple of things about it that I think are worth emphasizing, because we see quite a lot of multiple malformation conditions in clinical genetics, and they're very often associated with delay in development and learning difficulties. But that does not seem to be the case with VACTERL at all. The children develop normally and they have normal intelligence, which I think is great news. And also recurrence is very unusual. And we have very few clues as to its cause, so we don't know. So last slide. If you want to understand more about the cause of TOF in your child, bear in mind that the whole of the UK is covered by regional clinical genetic services. And so, for example, I work in the southwest, and I do clinics in all the outlying hospitals. So I'm based in Exeter, but we cover Torbay and Barnstable and Truro and all the rest of it. So essentially, there is a genetics clinic in pretty much every acute hospital in the UK. So your GP can refer you. I'm very happy for you to contact me with questions. I don't get a lot of queries, actually. If I was inundated, I wouldn't be putting my email address up there, but I'm not. So make use of your TOFS patrons if you've got a question. Catch me during the morning. I'm sorry I have to go at lunchtime, but I'm around this morning, and thank you for your attention. Happy to take any questions.
Thank you, Charles, for a very interesting
My pleasure.
presentation. Let's take questions from the floor.
Hi there, I'm Barbara Marie. This is my son Stephen. He's an adult TOF, 35. There's not a lot we haven't been through, so please talk to us later, anyone that wants to ask anything. But my first son, I lost because he had a tiny little valve, an urethral valve that hadn't developed by 1/16 of an inch. It was not picked up when I had him, and I brought him home, and it was backflowing his urine, so it actually was blowing his kidneys up. I had no idea. I took him in when he collapsed on me, and they gave him a colostomy, so the inevitable happened. He died in hospital, and I still haven't really got over that. And then I had this one that they told me hadn't got a food gullet, and I was going, how long is this one going to live, you know? So would the tiny little urethral valve have been part of this?
It is part of, so kidney problems are part of VACTERL.
Yeah, so
okay. But he didn't have any of the other VACTERL things by the sounds of it.
No.
There's one study that that was done again, I think with some support from TOFS, where they looked at the incidence of malformations in the immediate family of TOF and VACTERL cases, and they found, I think it's quite interesting, they found a slightly increased incidence, although it wasn't a massive difference, but it seemed to be statistically significant. So and is your son an isolated TOF, or does he?
No, isolated. No one ever. We had never had another one before. And we
Does he have any other?
Yeah, he's got one big kidney and one small kidney joined together. He's got little bones missing out his fingers. So quite a few things Stephen has.
All right. Well, thanks.
Okay,
I'm sorry to hear about your first child.
Any other questions? Yeah, another question across there. Yeah.
Yes, you mentioned possibility of lost twin.
Yeah.
Is there a particular? Sorry, thank you. Is there a particular timeline for that? So, what kind of weeks of pregnancy?
Not really, because if you imagine a twin pregnancy starting off with identical twins, as I said in the talk, what happens is that they separate. All right. Now, what we're saying is that one of those twins is then fine. The other one seems to have the possibility of a risk of congenital malformations that can include TOF. That pregnancy is then at risk of failing because of the burden that the congenital malformations place, and it's often the heart one, because the heart in the embryo has got a very important role to play. But the point at which that malformation might become incompatible with life, that it could result in loss of a twin, is not really defined. It could be at any point. So it would be after the 8-week point, I guess, but then it could be any time from 8 weeks all the way to term and beyond.
Yeah, we've got another question over here. Yeah. Thanks.
I have these kind of bendy little fingers that bend about 30 degrees, both of them. But no other issues for me. But
you had a TOF though, did you?
Yes, my son TOF does have the bendy fingers. Mine.
But you don't yourself personally.
I was fine. And,
yeah.
And my father didn't, but his twin sister did have the bendy fingers. I wondered, and also my son with the TOF had absent ductus venosus as well.
Right. Anything else?
That's it. So, thankfully, that's the only thing. I mean, was it a sign, the fact that the bendy fingers you talk about Feingold? Is that?
It could be, yeah. I would ask to, or I can talk to you later if you like, or ask to be seen by a geneticist. I mean, we love that kind of stuff. We would be delighted to see you.
My friends at school measured it and measured it and measured it again, and they loved talking about it all the time. Yes.
Is this head size, your son's head size, is that within the normal range, or is it a bit small?
I think, yeah.
The bendy fingers may well be just an independent familial trait.
Yeah. Of course, much amusement to all of my class at school.
Any other questions? Yeah.
Hi. So my son is TOF. He's also a twin. But now, when he was born dichonic, so separate sex, separate embryo.
How old is he? And are they thought to be identical or non-identical?
Well, he's 7 months, and when we found out he was twins, we said there was a 30% chance of him being identical. But they don't look identical.
They're probably not then.
No, but you said that there's a... Yeah, but you said there's a correlation between identical twins, one of them having TOF or OA, but what is the correlation between non-identical twins and having TOF and OA?
Well, yes, that can still happen, obviously. The point I was making about twins was that the identical twins are overrepresented. It seems to be a thing that goes with being an identical twin, but that doesn't prevent non-identical twins from also having a TOF OA. That clearly can happen. And there, my neat little explanation about the way that twins form wouldn't apply, obviously. So I don't know. I think that puts you in the same mystery group, your son in the same mystery group as the majority of the others. We don't know.
Okay, because we did have him genetically tested by the 100,000.
Did you?
Yes.
Yeah.
And they found that there was no genetic.
So you've had a result back, have you?
Yeah, they got back to us
nothing.
a few months afterwards, and they
Yeah.
said that there was nothing
They didn't find
genetically
anything.
on both sides. So
Yeah.
it was just interesting to find that out.
Yeah. Okay.
Thank you.
Any other questions? Just one last question, yeah, please.
Just grab me over coffee if you've got questions.
Yeah, so I have a 13-year-old son who's a TOF, obviously. So obviously we've also gone through everything, but he still breathes very heavily. And when we've been to Great Ormond Street, they've given us an option to actually go in, and then they do some work where they make the valves wider.
Okay.
But the problem is they've always given us the option on whether we want to do it or not. Now I just wanted to find out from you if you have something like an opinion on that.
This is a TOF management question, isn't it? I think I'd defer to one of my surgical colleagues actually on that.
Okay, that's fine.
I'm sorry, I wouldn't.
Okay.
I wouldn't be able to help you with that.
All right, thanks.
Sorry.
Okay, thank you very much, Dr.
Okay.
Smith, for an